Welcome to Healthcare by the Numbers, a podcast that uncovers what's driving healthcare transformation. Join us each episode as Caravan Health leaders interview the brightest minds inspiring healthcare innovation and discuss the numbers which have shaped their thinking.
Welcome, everyone. I'm your host, Louise Yinug, Senior Policy Analyst at Caravan Health, and this is Healthcare by the Numbers, a podcast that explores the numbers driving change throughout our industry. To learn more about Caravan Health, this podcast, and to check out episodes of the show, visit caravanhealth.com. And be sure to sign up for our newsletter to be notified of future episodes. You can also visit our program page on Healthcare Now Radio and follow us on Twitter, LinkedIn, and Facebook under our username @Caravan Health. Today, I'm joined by two Caravan Health leaders, Lynn Barr, founder and executive chair, and Dr. Ashok Roy, Chief Medical Officer. We are delighted to welcome Quint Studer, a true healthcare visionary and friend of Caravan, to the program. Welcome to the podcast, everyone.
Thank you.
Well, thank you, Louise. This is Lynn, and I really appreciate being here today. I'm also joined by our Chief Medical Officer, Dr. Roy.
Hi. Yeah, Lynn and I are both very excited about Quint being on this podcast to really share his vision of where healthcare is going. Quint, can you introduce yourself?
Oh gosh, yes. I'm so excited. First of all, my heart is beating because I love Lynn Barr, as many people know. I love what she does. I love what she stands for. And because both of us have something very much in common. I started at a 35-bed hospital. I have a heart for these small hospitals that are so vital. And many people don't take interest in them because there's not a lot of profit, a lot of margin, and it's tough. But Lynn's always been a pioneer at that, so I'm very excited. Dr. Roy, I'm excited to you because you've been a leader in population health for a lot of years. So I'm just very, very grateful. And it's impossible to be unhappy if you're grateful. So I'm very happy today because I'm very grateful for being with you and being part of this wonderful work that Caravan does.
Oh, thank you so much, Quinn. And it's a real pleasure to work with you and to try to bring your view of how to help our safety net hospitals really thrive in this new world. And Caravan Health, we guide our partners in their journey transitioning to value-based care. And Quinn has been our longtime friend of both Caravan Health and the clients that we served. He's been recognized by Becker's Hospital Review as one of the 40 smartest people in healthcare. I'd like to meet the other 39. And today we welcome him back to our podcast to hear from him. Quinn, for those that are not familiar with you, what is the latest with your work?
I think the latest in my work is I looked at what was going on. I've written a book called The Calling, Why Healthcare is Special. And it's really helping people replenish themselves. It's helping people replenish their team and their organizations because we need that replenishment, which ties into a lot of work in the area of burnout. I wrote a book over 6 years ago on burnout for physicians, and I think I was ahead of my time. The pain was there, but not as severe today. So I've really created a lot of tools that seem to be really attractive for physicians in the area of stress, well-being, and trauma. And the last thing I'm doing, Lynch, and I'm really excited about, is I don't believe healthcare can be a cookie cutter at times. It's really looking at organizations and coming up with how do we design something that's very specific to their pain threshold so they can be sustainable. Because if you're not sustainable, particularly financially, you don't exist. And that comes today with making sure you have the right physicians, the right employees that fulfill your mission. So that's what I'm working on right now, Lynn. I'm sorry I go into such detail because I'm so passionate and so excited about the work.
In each of our shows, we like to spotlight and frame our conversation with some of the numbers impacting our industry today. Today, we're going to start by talking about what happens when a rural hospital closes. So when a rural hospital closes, residents have to travel much further for health services. According to the Government Accountability Office, patients have to travel 20.5 more miles further for inpatient services. And for less common services, the distance can be even greater. For example, for substance abuse treatment, the distance can be increased by up to 39.1 miles. When a rural hospital closes, it's much harder to find a physician. The number of physicians after a closure drops dramatically. In one study, it dropped from 71.2 to 59.7 physicians per 100,000 residents. And now in late 2021, we're entering into a time of unprecedented job churn across the country, and the healthcare sector certainly hasn't been spared. We have a shortage of 13,800 primary care physicians in high need areas nationwide, and especially this is true for rural communities. And those shortages are just expected to increase over time to 20,000 primary care physicians by 2025, according to the federal government, and double that number by 2030. So those are the numbers. It's clear there's a lot of work to be done. Quint, what numbers stand out to you the most?
I think when you take it from numbers, you look at what does it mean to a community. I wrote a book called Building a Vibrant Community. And one of the things you find out is when the hospital closes, the community starts dying. They're one of the major employers in town. People sort of halo because we have a hospital, they drive by it. So I think the fact is a hospital closing is part of a death spiral for an entire community. But I think I want to put in a personal note for myself and why this is in my heart. In July of 1995, my wife, Rishi, and my two youngest children, Mallory, Michael, and I were in Deadwood, South Dakota at a campground camping. They were doing a little bit of construction work around there, moving some dirt around, but nothing major. My son and I were kicking a soccer ball. My wife was in the pool with Mallory. And at 3:00, I knew I had to make a phone call. And back then there weren't cell phones everywhere. So I went into the laundry room, check-in room, everything by wood room at the campground. I put Mike, my son, in a fenced-in area with the pool, but he wasn't swimming. He was just waiting for me to come out, kicking a soccer ball around. And I went to make a phone call. It seemed like a matter of seconds. A man ran in and said, "Dial 911, a little boy's been crushed." And I don't know why, but I knew that was my son. And what happened is the soccer ball went over the fence. He went to get it. I'm sure people told him not to, but he didn't hear them. There was a guy on a bobcat, a 4,800-pound bobcat, moving some dirt close to the pool. And my son went down to pick up the soccer ball, and he was crushed by the bobcat. When I ran out, there was pandemonium everywhere. My wife was yelling, "There's no heartbeat, there's no pulse," and my son was gray. An ambulance pulled up. They said they had a pulse. They put him in that ambulance. They took him to Deadwood General Hospital, which is a small critical access hospital. They got him stabilized. He was bleeding internally, and they transferred him to a large hospital. Today, he's 34. He's healthy, but we didn't know if he's going to live or die, nor did the doctors for the first 72 hours. So I can sit here and say he would have survived if that hospital wasn't around, because they could have taken him the hour and 20 minutes. That's how far away we were from Rapid City, and he might have been okay, but I really didn't want to. So without a critical access hospital, a safety net hospital, we might not have our son, Michael. So this is more than numbers to me. This is, if you don't have a small hospital, a rural hospital, a safety net hospital, you lose people. So this is about saving lives. And that's why I love what Caravan does, because I think they're an organization that saves hospitals, saves communities, thus also saves lives.
Oh, thanks, Quint. That was very, very moving. I share with you a passion about community hospitals. I grew up very poor, and my mom was on Medicaid. And she was disabled, and the only real social services that were in most of the towns we lived in, which were many, was the church and the hospital, right? Those were the players, right? And that's true of our rural communities today. And the role that they play is so much beyond inpatient care. They are the anchor of the community and the place that where I found as a young child love and support. And I feel a tremendous that I owe them a tremendous amount, and anything that I can do in my life to support community hospitals that supported, my poor family and took care of them and gave them dignity and care, even though they had no insurance or were underinsured, is just it's an incredibly important thing to keep going. And so And as I work, I live in a rural community today, and I've worked in a critical access hospital, and watching and seeing how connected they are to that social safety net is incredibly important. But I also see organizations that are deeply under-resourced. They've got all the heart, but none of the money, none of the people, and none of the expertise, none of the scale, all of the issues, the things that large hospital systems might have, they do not have. And so I've been trying to work with them to help them move into these new payment models as a payment model. How do they get more of those dollars? And, we're talking about healthcare by the numbers. A small rural hospital that supports 10,000 patients is supporting $10,000 of healthcare spend per patient. There's $100 million of healthcare spend in that small community, $100 million. And they've got $10 million of drug spend in that community. And so I think that we need to stop thinking of ourselves as hospitals and start thinking about ourselves as the delivers of care for our community, and that they need a lot more than just inpatient and outpatient services. They need services that take care of them in their home. Our seniors are aging in their communities, and the children have left. How can our rural hospitals step up and help the seniors in their community? How can they use their 340B program to pass on discounts to the patients that can't afford their drugs? How can we make the hospital more and more relevant than it is today, and strengthen both the system, both for patients and providers? So Quint, I need to ask you a question about this, because a lot of the small hospitals are very concerned about value-based care. They think it's going to take away from them as opposed to growing them, and that hasn't been our experience. We're working with hundreds of these hospitals, and we're seeing that it grows both their mind, their spirit, and their bottom line. But I was just curious, like, how does Caravan sort of help them understand what we can do to help them, and how are we maybe different than other people out there that are offering similar services?
Well, I think, Lynn, when I look at this, it's interesting because, one of the things I look at it, I worked in a 35-bed hospital for 3 years. And one of the things that you learn about is you don't have the resources and you don't have the expertise. In fact, my belief, if you work in a small hospital, particularly as a CEO or an administration, you actually have to be better than the people in the big hospitals because you don't have some of the resources. So I think when you look at it, one of the things that we have to do is bring them cost-effective resources to sort of build part of their administrative team, because they're not going to have it. And when I look at Caravan, and I'm going to tell a real paradoxical story here in just a few minutes because it's so different. So, for example, if you look at Caravan, if you look at Eaton Rapid Medical Center in Eaton Rapids, Michigan. Now, they've gone into the covered lives. And if you look at what they've done for the 488 covered lives, their chronic care management's increased from 1.2% to 14%. Because you're right, exactly. That you're in a small safety net hospital. Heck, you're average, maybe even have the Rotary Club meeting in your cafeteria. You're doing everything. You are the community center for that organization. So you just can't look at just inpatient or outpatient. You got to look at chronic care management. You got to look at end of care management. You got to look at sometimes equipment. So how do you do that? You become financially sustainable. And that's really the key. How do you become financially sustainable while meeting your mission? If you look at Olmsted Medical Center in Rochester, Minnesota, there's what you've done to them with their population health management by changing their advanced care program. You set a goal of 50% in a standardized documentation process, which we know ties into reimbursement, and now they're already at 61%. Now, interesting enough, what happens is I look at major players. So, for example, I was at UPMC yesterday, which I love. Leslie Davis is a great CEO, and they're one of the biggest healthcare systems in the world. And what are they doing? They're looking at population health. I'm on the board of TriHealth in Cincinnati, Ohio, a couple $1 billion organization led by Mark Clement. What are they doing? They're looking at population health because they're trying to look at where the puck is going, as Wayne Gretzky would say, and they're trying to get there first. And I think what happens in a smaller place, you're so busy working in the job. Sometimes you don't get to work on the job because you're so busy making sure, do I have staffing for today? What about that physician I need? So you're caught up, they call it working in the job, not on the job, that you're going to get to it. But if you don't get to it, now it's too late. And sometimes healthcare CEOs need to be bold and they need to be courageous and they need to look around the corner. And look around the corner is what Caravan brings to a rural safety net type CEO. Resources and technique to prepare them for the future while they're even getting better in today. So that's, again, why I'm such a big fan. But it takes a courageous CEO. It takes a courageous CEO to say, yeah, we're doing okay right now, but I want to do okay 3 years from now, 5 years from now, and so on. So that's how I look upon it, Lynn. And that's why I'm such a big believer in value-based care, because it's where the puck is going. And it's already gotten there for some people. And it will get there for rural healthcare, because if it's there for the big players, it's just a matter of time. So I'd rather do it when I had the choice to do it rather than I had no choice to do it, so I can get it right.
Quint, you were talking about, obviously, lack of resources, building up, support for the hospital. But what about rural physicians? Do you see their needs different from what the hospital needs?
Well, I think rural physicians got to be loved, because their job is incredible. And I wrote a book called Healing Physician Burnout, 2015, because a doctor called me, Dr. George Ford, and he said, Quint, and my sister actually was in the hospital at the time dying of cancer. And he called me, and I think I was emotional. I was open, and I've tried to always be, but he was very concerned about burnout because he'd gone through it. And he said, Quint, I guess now they would call it an influencer. I don't think they called it influencer back then. Could you look into physician burnout? So I did, and I wrote a book called Healing Physician Burnout. And I almost think Dr. Roy was ahead of its time a little bit. The pain point wasn't there. So if you look at rural healthcare, if you look at the physician, they're really the community leader. So I was in a small community in Florida, and I met the only pulmonologist in the community, and he walked through all the patients that he took care of, particularly during COVID. So I think you always want to treat your doctors great. You always want to make sure you're making them feel valued, and you never want to take them for granted. So in essence, a small rural hospital has to be better at physician engagement than anyone else. Because again, when I was in Chicago, we had 30-something orthopedic surgeons. If we lose one orthopedic surgeon, it's sort of sad, but it's 3% of our orthopedic surgical revenue. If I'm in a small hospital and I lose a physician, or a physician decides to exit, I might not be able to take care of those patients. So it's both, I'm losing the revenue, but I'm also losing the trust of the community that I can't provide the services they need. So I think you have to be better, again, at physician engagement in a small rural community than you do anywhere else in the world.
So for physician engagement, it's okay. We know we need to make needs, but what specifically do they need to, even to recruit? Because I get tons of flyers to be like, hey, move out here, great quality of life. But it's, as an urban physician, right? It's tough. And with my colleagues, we're like, okay, it's appealing, but I'm not going to move out there because, again, I don't want to face the same challenges of, great, I move out there, I don't have the staff to hire. Because a lot of our clients, they're like, they agree with our programs, they support it, but they're like, I just don't have the staff to execute this. I know it's best for my patients, but I just have to survive, right? Just see the patients who walk in versus planning for population health.
I think a few things when it comes to doctors. I think you got to differentiate yourself. So I was in charge of physician recruitment at a place I was at. And one of the things I did that nobody else did, I actually went to the community to meet the doctor. Instead of waiting for the doctor to come to me, I would know when they were interested before they ever even got to our community. I would go meet them. That would let me see what their community's like, where they're practicing, getting to know them. I'd even at night, if they would let me, go to their office setting so I would see what it was like. I also think small hospitals always look for advantageous ideas right now. One of the things, and again, this is the nature of the beast, most of the large healthcare systems, doctors are no longer in charge of hiring their partners and who they're going to be taking call with. That's now handled at a corporate institution. What do doctors want? They want input. So one of the great things about a small rural healthcare system or hospital is a physician can have input. Physicians want to be involved in decision making. You can do that in a small community. Physicians want to know who takes their call. You can do that in a small community. So I think you have to not only look at the advantages, but you have to look at where they're at. So when you get them in your community, you can show the differential. And what do doctors want? They want input. They want things to run well. I'll give you a story that I think is a classic. I was in a small community, and the CO there hospital does quite well. And he said, Quint, there's 2 orthopedic surgeons that live about 35 minutes from here, 45 minutes from here, and they've just moved all their patients over to our organization. And not only did they move over themselves, they moved their patients. And I went and met them. And I said, this is amazing. How come you're doing surgery here, which means you have to drive a little bit to and from this place? And he said, because I'm talking to you because we're ahead of schedule. So I think a small hospital can run better. They can stay on task. They can also do something else, Dr. Roy. They can individualize the environment to the doctor. We're in big, huge systems with the amount of standardization, which isn't the worst thing, but you sometimes can't standardize that physician experience. And just like we want to standardize a patient experience, an employee experience, we want to standardize that physician experience. So what do they want? They want input, and they want to make sure things run well, because that shows respect. And you can deliver that in a rural community today.
That's great, Quinn. I want to stay on this topic a little bit. One of the best stories I heard was actually one of our hospitals up in Wisconsin who was really struggling to get physicians to come work for him. And what he ended up doing was offering a 4x10 shifts. And so he had doctors coming from Minneapolis that would work 4 days, and they would have 3 days off, no call. And it was like, that was very attractive, because people wanted more time with their families. And so there are different strategies that we can use to attract physicians to our community. And we have to really consider the issues around their family and education and jobs for their family. But now with the new telehealth, where people can work anywhere, we may have solved the employment issue, for the family, and hopefully we'll be using more and more online tools to support better education in our rural communities as well. So maybe with the pandemic, there may be some long-term benefits to that. But one of the problems that I really have struggled with in rural communities is trying to build trust between the hospital CEO and the physician, right? And maybe you can talk a little bit about the barriers to that and the tension between them, and how can we build stronger trust. But even more than that, what I perceived, and I've been in probably more than 100 rural hospitals now, what I perceive is their concerns about a lack of trust of the government. And I don't know if that's just the doctors, by the way, but here, they're entering into this, in fee for service. I do the work, I get paid. It's simple, right? I don't have to trust you. If you don't pay me, I'll sue you, right? Now in value-based payments, I do the work and I'm trusting you with all these formulas and stuff that you're going to compensate me for that. I find that's probably a big struggle for a lot of people in our rural communities. So can you talk about trust and how to build trust, between the hospital and the physician, and then with the rural community and the payers, so that everybody can work together?
Well, sure. I think there's a few things, Lynn, and I'll try to remember all your points. And if I miss something, just remind me again. I think number one is, we have to realize we're just not unique. It's sort of like going to hospitals and saying, we've really been impacted by COVID. And I say, well, so is everyone. So it's now who can handle it the best. So I think there's always been a big trust. There's a distrust, certainly, for physicians with one, usually insurance companies. It's usually government. It's somebody. But let's talk about the first question. I think the way you build trust with physicians is you don't expect trust just to come to you. You ask them, what do they want? And one of the things you do with physicians, I learned this from heads of surgery. They have something called a preference card. And they sit down with the doctor, like a surgeon, and they say, we want to make sure the surgery is great for your patients. They ask questions like surgical kit. They even talk about temperature. They talk about the music they want played. They talk about basically, we want this whole surgery to go well. So what does it mean for you to have a great experience as the surgeon? I think, Lynn, we can do that with all physicians, and we can create these preferences, because what we have to do is build trust, and you build trust by delivering for them on a regular basis. And once you do, I think the loyalty comes. So you earn the loyalty, you don't expect the loyalty, but you do it by asking specific questions. So Dr. Roy, I want you to have a great experience here. Tell me, let's do this, Dr. Roy. Do you mind if we do this right now?
Of course.
Go back to your days, and you're a physician. And I say to you, I'm the CEO, and I say, Dr. Roy, we want this to be a great place for you. Tell us what we need to provide to you on a regular basis in taking care of your patients that would make this a great place for you to practice medicine.
Again, the experience is different from a surgeon, from internal medicine guy, which I am. But really, it's
medicine. I get that. As an internal medicine physician, are you going to, let's say, a small rural hospital, we might not have a hospitalist, right?
Correct.
So as an internal medicine physician or an employee that we're going to be running your outpatient facility, I want to know what's going to make this a great place for you to work. And sometimes you're going to have to think about it a little bit. And what are you going to need? So I know this is a little throwing on you, not throwing up if I feel like throwing up right now, throwing out at you. But when you look at a work environment from an employer, well, I might be your employer in a small rural network, what's some things I can do to make this a great place for you to practice medicine?
Yeah, the first thing is just asking that question is huge, right? Because again, having worked for large healthcare systems, they don't ask you that. They're like, this is what you have, deal with it, right? But if my responsibilities were outpatient plus round on patients on inside the hospital, it's basically I need to make that efficient, right? I need to have things prepared for me. So I need all the input from the care managers to the discharge planners, all need to be there where I come around and boom, 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 where we're able to do all that efficiently. Ideally, if it was an ideal thing, on the timeline that we come at. And for my notes, that either a scribe or a type of scribing system where I'm able to sign off on all notes all at the same time, just because I don't want to dilly-dally there. And then on the outpatient side, it really is, I just need the minimum support. I need scheduling flexibility, and I need to know what I'm going to be graded on, or if there's a incentive, like make it clear, make it simple, and make sure I could track it.
And that's why I like what we're doing with Caravan, is creating these design and build systems for hospitals. So I'm giving an example, Dr. Roy, what I did with this. We made reference cards when I was president of a hospital for everybody. So that I would say to the internist, particularly without a hospitalist, when do you like to round in the morning? When can I plan on you being in the hospital? And they'd say, hey, I like to round around 7 o'clock. What would you like in place when you round? Well, where do you go first? What do you want? And big thing is I want the nurses prepared when I come up there on what's going on with the patient, so I know exactly what's going on. I want the reports to be available. I want this, I want that, I want this. So what we can do is create a preference card, and then we go to the outpatient arena. What do you need? What do you need there? And I think that's really, really vital, because what we want to do is show the doctors we respect them. And how do you show respect? Like you said, Dr. Roy, it's making sure you're efficient. So along with Caravan, creating these tools for these rural hospitals and these physicians, and that'll knock their socks off. Can you imagine, Dr. Roy, that I'm interviewing you for job, and I show you preference cards we use with our other rural physicians that are there. We talk about how it's run. We're prepared for you. It's going to knock your socks off. And you always have to take your current environment and not look at why it's not an advantage to you. Look at how it is an advantage to you. So those are some thoughts, Lynn, that I would do in that rural network, that rural environment. Now, when it comes to the community, I think it's really important. And that's another thing I love what we're doing with Caravan is, we've done a lot of work on building small rural communities, vibrant communities, because I think what I love about what you're doing and what you're launching here is we're not only going to make your hospital and health system more sustainable, we're going to make your community more sustainable, because, you're only as good as your place. And for us to have a great rural network, a rural hospital, we need to create an attractive place that's going to, bring workers and employees. And that's what you've done, Lynn, with your story about the hospital in Wisconsin, is they've created a better place. And one of the things you brought up, Dr. Roy, is flexibility. And in many huge systems today, the doctors don't feel that way anymore. They feel like they're looked upon as a productive piece of machinery. And we want to bring it back to the days when doctors felt valued, felt loved, because they are.
That's a great point, Quint. And I remember, when I was in my very first days of trying to start the National Rural ACO, and I'm going around to all these hospitals, and I had this doctor he just lost it, and he was, you're just another person that's going to come in and tell me to do more and pay me less. I'm so tired of you people. You just, and you could tell he was completely disrespected. He felt completely, and this whole idea that, our health system isn't adequate because of our doctors is not the right idea. Our health system is not adequate because we lack the systems. Our payment model is terrible, and we just don't have the systems in place to support what we need to do. And so what Caravan's approach on this was to say, we want to create access to care, and we don't think doctors should be doing quality reporting. The fact that a physician's sitting there and not spending time with the patient, but is spending time in the EMR to make sure that they've had their mammogram is disrespectful to both the patient and the physician. And so but what were we going to do? There was no access. So the very first thing we did was said, every clinic needs a nurse. And we're going to take a lot of this population health work, and the nurse who will then spend a half hour, an hour with the patient talking about their kids and their family will do this quality work for you. And at the same time, connect with that patient, because we can't just treat their disease. We need to treat the whole patient. And that means we need to connect with them and care about them and about their food, about their home, about their children, about everything about them. And this is what rural does better than anyone. So, Quint, I can't have not say that the rural value-based care model has been one of the most successful programs in Medicare's history. We saved Medicare hundreds of millions of dollars. They weren't under risk. It was free for them. The government gave them the money to do it, and they crushed it because they could get around a table. They could make a decision. They cared desperately about the people in their community and will work incredibly hard just to give them a better life. And so these are strengths of the rural community. Our weaknesses is staffing and dollars, but we can think how to work smarter, and also how to find out these other stories from our peers that are solving these problems in really innovative ways and bringing that to the table for them. So I see rural as being a really a beacon of hope for what the rest of the country can look like when the community, the physicians, and the hospitals all have a common goal of the health and well-being of the patients.
I think, Lynn, one of the last questions you asked, which I didn't answer, is the trust issue. And I think when you look at trust, you look at who are you partnering with? because, if I'm working in a physician in a small rural hospital, I know they're struggling in many areas because of the nature of the beast, staffing. So all of a sudden somebody says we're doing something now, I'm going to say, whoa, how can we do that? So it depends on bringing your resources. And this, I hope people can connect the dots because it's not a healthcare story. But where I live, we decided to offer a mentoring program. And we decided to offer to small businesses mentors that could help them. And then we went out and hired MIT, who has a mentoring program, to come in and help us set up this mentoring program. Now, I believe if we would have said we're setting up this mentoring program, I think it would have been okay. But when we brought in a credible place like MIT, all of a sudden it was, wow, this will be good. Same thing in We Weaver program with other players like that. So I think with your history, your background, the success of looking at your organizations, I think Caravan is sort of a gold standard. So if the hospital CEO explains to them who Caravan is, why Caravan, that we're not going this alone, I think that builds up that trust. Because I think for a doctor, they look at who are we partnering with? Who are you looking at? Whether it's equipment, whether it's different technology. So I think you bring a gold standard, which really helps build up the trust, Lynn.
So one question is, we've been talking about these barriers. How do you see the role of technology, helping these barriers, and especially in rural areas where, during COVID-19, there was a big push to telemedicine, but a lot of rural patients didn't have the bandwidth or, the broadband to even have telemedicine visits. So losing out on opportunities. But given the social determinants of health, the role of the hospital in the community, how do you see technology playing a role?
I think that's where we have to create also better, vibrant communities. For example, I was at Lafayette, Louisiana a couple of weeks ago, and one of the big pushes was we met with the hospitals and the community, and the chamber met to broadband. How do we get broadband? So there's a question that not every healthcare provider can answer. But I think if we go back to technology, Dr. Roy, here's what we can offer to, again, the advantages of being a rural hospital, rural health system. And I wrote my book, Healing Physician Burnout. One of the biggest frustrations with physicians, their lack of input on technology. It seemed like somebody bought a software system or technology at corporate headquarters who has never touched a patient in their entire life and said, here's the tool we're using, or only a few doctors made this decision at a corporate level. So I think when technology, it really becomes a collaborative approach to technology. And I think when you give physicians that input into technology, and then I think it's the skill building of technology. You just don't provide technology. So for example, telehealth, one of the things that we like to create is micro-learning techniques to help physicians. Because what happens with physicians, and I've done a lot of research on this, physicians are some of the most highly competent people in the world. They're high performers. And they're very structured. So they get used to doing something the same way all the time. Creatures of habit. So when you ask a doctor, when do you do things, they can almost tell you specifically when they do things. So what they become something, Dr. Roy, is we call they're unconsciously competent, means they've done it so much, so often that it almost is second nature to them. That is great unless there's change. Now, when you change a software tool, change a system, change something, the normal tendency of a human being is to go backwards. It's going to take me a while to learn the new skill. And I think with physicians, you have to have empathy with technology to realize there's a learning curve, and you have to make sure the physician's okay knowing that they're going to go backwards, but so they go forward. And as Lynn said, that's sometimes making sure that we provide them with not only training, but skill building and extra resources while they're going through the training. So I've done a lot on this with physicians. Physicians like being the top of the game, and anything that gets in the way of them being top of the game can be a bit frustrating for them.
That's a great point, Quint. It has been such a pleasure having you on Healthcare by the Numbers. Do you have any final thoughts or comments to our audience today?
Yeah, I want to thank you, Lynn. You and I have been together a long time. When I look at 40 smartest people in healthcare, if you ask me who the other 39 would be, you could be all 39. But what I love not only is your intelligence, and I love your passion. And this isn't about the number that you're looking at, is getting the numbers so organizations can be financially sustainable, provide better care to make better communities. So I just want to say you're the gold standard, and I'm just so excited to be with you today. And also what I love about you is you're always looking around the corner. And I think that's hard for a hospital CEO because we're so busy just fixing it today. And I think what you bring and what Caravan brings is that look around the corner to help us navigate not only today's healthcare world, but tomorrow's healthcare world. So all I want to say is thank you so much for what you and what Caravan does to save lives.
Thank you so much, Quint, for joining us today. And thank you, Lynn, and thank you, Dr. Roy, for hosting this discussion. For our audience, if you'd like to learn more about Quint Studer and the collaborative work that he's doing alongside Caravan Health, you can find more information at www.caravanhealth.com. Thanks so much to everyone for listening today. We are Caravan Health, and this has been Healthcare by the Numbers. Until next time, take care.